but I'll briefly comment just for the sake of it. If you scroll in this axial there, Chase, just for a moment,
Mhm.
and you can stop a bit, go up a bit. Yeah. So on this one, what we had, and I'm gonna use this one just to briefly comment, is that we had this pattern that we had the normatization seen here and closer, and of course you see the the precellar type, all this bone in the bottom part of the cella, but more importantly, so in the left side we had for the bone in front of the cella. So we basically had to skeletonize around the pituitary gland in the left carotid to get the type of exposure that we needed. So that required a bit more work and working around the diploic components of the bone in the sphenoid sinus. Um, so maybe let's go ahead just so we can continue then.
My next question is, which is the correct description of Knosp grade 3A macroadenoma? And for students in the room, Knosp grading is used to predict the extent of cavernous sinus invasion by an adenoma radiographically. And again, to register, you can use the QR code and text Mayo Florida 165 to 22333. We'll give it a minute. And just very briefly, I wanted to, it was very helpful for me as a medical student to understand what Knosp grading was when reviewing this case. So I just wanted to talk about how it's used. There's 3 lines that you have to understand that are hypothetical lines that you can use on the MRI. It's the medial tangent line, intercarotid line, and the lateral tangent line. And these are all tangential lines between the cavernous segment of the ICA and the supraclinoid segment of the ICA. The image on the left is a screenshot from our patient. So this would be the medial tangent line, the intercarotid line, and the lateral tangential line. Here we could see that there is extension past the lateral tangential line superior to the cavernous ICA. So this would be considered a Knosp grade 3 macroadenoma. If it was inferior, it would be 3B. The rest of the Knosp grading is displayed on the bottom right of the screen, but for the sake of time, we will keep moving. So given her lab findings, her cushingoid appearance, and her mass on her MRI, the most probable diagnosis is a pituitary adenoma corticotroph type. Less probable diagnosis includes an intracellular meningioma or a craniopharyngioma. So just to recap, this was a 53-year-old female with ACTH-dependent Cushing's disease and a 1.5 centimeter pituitary macroadenoma with probable SI to cavernous sinus invasion. We came up with a plan that we thought best for her was a endoscopic endonasal transsphenoidal approach to attempt a gross total resection. We thought this would be the best chance we had to exceed hormone control of her excessive hormonal imbalance. Other options for her were observation, stereotactic radiotherapy, or other surgical approaches. Potential risks and complications were discussed with the patient. Some notable ones are hemorrhage or neurological deficits intraoperatively. Postoperative, there's always the chance of a CSF leak, infection, septal perforation, and hormonal imbalances of diabetes insipidus being in the acute postoperative setting. However, long-term hypopituitarism is seen in 5% of cases of patients who undergo transsphenoidal resection. So here's the video. And I will start it, and JP, you just let me know.
I mean, I don't know if Dr. Donaldson has a better connection right now, so I start describing. But please, Dr. Donaldson, if you're able to connect, please just let us know, and happy to hear from you. But you can play the video, Chase, for now. So here you see. Oh, okay. I think I heard Dr. Donaldson.
Yeah, we're talking at the same time. Sorry. I'm here. Sorry, my connection was bad in my office. So what we're starting with is just an injection of the middle turbinate bilaterally. You see me pushing over, we call it lateralizing the middle turbinate so I can see the superior turbinate. And then in order to see the superior turbinate, I kind of lateralize that, and that'll show me my sphenoid. And from the sphenoid, I open this area up. So it looks like this video is showing what can happen, which is that there's a small branch of that posterior nasal artery that can bleed. And when you're doing a sphenoidotomy, so you should just be prepared to have some type of cauterization device available. This is the posterior septectomy. There's different techniques. I like to cauterize it before I microdebride, just because I think this helps with hemostasis, but it certainly is more of a technique desire than a requirement. Her bone was really thick, so I actually used the sonopet much earlier to actually drill down the posterior, the perpendicular plate of the ethmoid bone, which is part of the septum, before I started the sphenoid rostrum. And then you see me here drilling down some of that inner sinus septum and opening up the anterior wall of the sphenoid sinus a little bit more in preparation for surgery.
Thank you, Dr. Donaldson. Yeah, and then here you see that, can you stop for a second, Chase? And just be mindful, yeah, it's gonna be pausing, playing and pausing. So you see that we didn't see the cell as we usually see in cases like, you know, pituitaries, because of the bone that was so thick. So we had to go and find the pituitary, find the cella, I'm sorry, and the pituitary gland in the dura as our first landmark, and then to expand from there. So that's the first thing. This is what you see right there in the middle. Play again, Chase. And then we knew, because of the lateral extension towards the left side, that we had to extend towards that side. But every time we have, you know, a pituitary adenoma, you know, in our point of view, we should have a full visualization, at least of the four corners of the cella region. So the cavernous sinus on the right, cavernous sinus on the left, superior intercavernous sinus and inferior intercavernous sinus to the best of our ability. It's not that you need to fully expose the cavernous sinus on both sides, but beneficial to have, you know, the medial aspect of the cavernous sinus. So on the right side, it's kind of okay, but the left side, we need to get the clinoid ICA, we need to get the anterior wall of the cavernous sinus exposed, because as we have a Cushing's tumor and as we have potential invasion of the cavernous sinus, we want to explore the cavernous sinus and we want to potentially resect the medial wall. So the plan here was to not only explore the left cavernous sinus, but to do the best we can to achieve selective resection of the medial wall of the cavernous sinus. What you see there, I got this thing from the lab actually to work a lot with double ball probes that helps dissect. You see the Doppler, and you can see if you stop the video. Yeah, and you see here, and what you see here, of course, this is the dura covering the pituitary. And then here you see bluish, this is the anterior face of the cavernous sinus. And right here, you can't see very well because I really didn't fully expose, which you're gonna see that's gonna be one of the limitations that I had for maneuverability. But I had the part of the clinoid ICA exposed on the left, but I don't have a full exposure as I would favor for a case. Go back, please.
Sorry.
Okay, go back a bit. Okay. Okay, you can play there. That's fine. As we would like to usually have. But anyways, that's why the Doppler is so important, because in the end of the day, this is the way we see it. This is really a carotid surgery. I'm sorry. So we need to be very comfortable working around the cavernous and the carotid. So you see, we open the dura in a kind of cruciate type like fashion, and then we preserve the planes. And I have to guide you all to see a beautiful presentation that Dr. Alan Montazer shared with us a couple of weeks ago on this topic of the planes of the pituitary sella and extracapsular, because it was a beautiful presentation as well. But you see that here the goal is to find the plane between the dura, the pituitary gland, and the tumor will be attached, although you can see here some of the tumor kind of like coming on view. And then here, as I was dissecting, I separate from the bottom part the plane between the tumor and the dura. And then you have the front view, and then we find that plane between the normal gland, which is here, and the pituitary tumor that is here. After that plane is created, you see that once again, go to the bottom, go laterally, and then you try to separate the tumor from the gland. In this case, we're trying to preserve that pseudocapsular plane. But once again, the tumor has an lateral extension on the left side, and that would preclude us, at least preclude me, of achieving a full in block resection. But to try to preserve the pseudocapsular plane remains important, so you can separate the part that you definitely must separate, which is the one in contact with the gland. So we went ahead and and we mobilize the tumor. You see that the tumor is slowly kind of breaking from inside out, and that's fine. You just kind of need to preserve the planes. Take your time. I like this called the hockey stick to celebrate our Canadians hockey players, and then here we got the round knife to keep dissecting that. Once you found the plane, you quite often has to debulk a bit, and that's what we're doing here. And then sending, of course, tumor for pathology and so on and so forth. But trying to preserve the separation planes between the normal gland and the abnormal tissue. So you see the normal gland, orange, and the tumor here in yellow. Once that's done, we decide, okay, let's attack the cavernous sinus component, and the one going towards the left superior aspect. And you see here, soft tumor, and basically you can just explore that initially, which is what we decided to do. So we just explore from inside out or from medial to lateral, which is the most classic technique. And then you see here, continuing to debulk that tumor. And you got a big chunk of it in that moment there. Once that most medial part was clear, can you stop the video for a moment? Just be mindful not to, to play.
Oh my
No. Go back a bit. That's fine. That's fine. No, you were good there where you were. Okay. So what I want to show you now, once we clear the cellar component or the medial aspect, then we had to attack and explore the cavernous sinus. So up to here, we're still just cleaning the portions that are in the cellar space, and this is the one most lateral component. And then you go and you clean as much as possible. You got to be really obsessive compulsive because it's a secreting tumor. And then here, what you see, I don't know if you can stop, but just be careful, Chase, so you don't go to the next slide. Okay, so what I'm trying to show in this part of the video here is the concept of how you can, open the two membranes that will form the walls of the cavernous sinus. You have a medial wall and you have an anterior wall. Where you see my dissector going here is I'm opening through the communication. So the cavernous sinus communicates with the superior intercavernous sinus and with the inferior intercavernous sinus. The superior intercavernous sinus, you often don't go there because you don't want to create a CSF leak, but the inferior intercavernous sinus, you don't really have anything to stop you from there. Since I already had the anterior wall exposed, as we dissected, it creates a plane, almost like a vacuum between the two walls. And I just benefited of this in this case. So play again the video, be mindful not to go to the next slide. Thank you. And then you're gonna see that at some point, as I'm dissecting, I see some venous bleeding, and then I use the feather blade to open that space. And then you see venous oozing, which is expected. You do expect to see venous bleeding coming. And that's what you see right there. So I'm opening the anterior wall using that plane. So I use a bit of a different technique in this case. Rather than going from front to back, just went from medial to lateral. And then continue exploring here. So I continue to go at this point posterior and medial to the medial wall. So I'm not yet resecting the medial wall of the cavernous sinus. We're just working and then going towards the posterior to the carotid, and that's tumor that you see there. So this is the carotid that I'm retracting here. I'm going medial to the medial wall, so I'm not inside the cavernous sinus, and I'm cleaning now towards the top of the roof of the region of the cavernous sinus as well. But once again, not yet opening the medial wall. Now I'm transecting the medial wall. So you see dissection from lateral to medial. And it's interesting because this is being done with a 30-degree scope, which is usually not what we do, but this is the angle that required. And then as I dissect this medial wall, as you see here, we can see the carotid fully exposed here. And then I continue to do dissection with a straight dissector. We can irrigate and make sure to create that plane of separation, and then you continue pushing. You just mobilize that wall from lateral to medial, away from the carotid. There are some ligaments that will connect that wall. After those are cut, you can go and transect the medial wall, the superior aspect that you see there, and then in the inferior aspect. And then we went all the way to the back aspect, all the way close to the next step is the inferior hypophyseal artery, and the posterior clinoid will be located behind that. So you're gonna see me as the next step, mobilizing from the floor of the sella all the way behind to get that access. And then here we are already now after fully opening the medial wall, we're working now fully inside the cavernous sinus. As we are cleaning this space, I don't see tumor inside or medial to the carotid inside the cavernous sinus, but that's cleaning of the medial wall. So here we are cutting, and you can see that the angle of approach is definitely not excellent. That's because of the bone in this sphenoid that was super thick, and I didn't fully drill laterally as I would need in this case. And then I decided, okay, I'm gonna have to do a selective resection. The most posterior part of the medial wall was left, the one close to the inferior hypophyseal, because I didn't feel that I had good control, and we felt that there was no really a lot of tumor, or there was no tumor there. So just decided to coagulate, as you see there in black, and then cleaning as much as possible to the top and to the roof to make sure that we wouldn't leave anything above the carotid. I think after that we got this nice control, hemostasis, and then we went ahead with the closure. And you see here gel phone, and then Dr. Donaldson came back, and you see here some biodesign, Surge's cell, and gel phone. We had no CSF leak in this case. Okay, good. Thank you.
Dr. Gentoff isn't available for the call this morning, so he recorded his slides. The next two slides are recorded slides from him regarding the pathology.
We are not hearing it, Chase. Maybe did you share the sound, but maybe just
Oh, you can't hear it?
no, you probably didn't share the sound, but just tell us what we have.
Here he was talking about this is unusual as these cells display some nuclear atypia, which is unusual for pituitary adenomas. However, it didn't change the overall grade of the tumor, as the Ki 67 staining was still less than normal. So he just noted that this was unusual for a macroadenoma with this nuclear atypia. And on the next slide, he notes that on the immunohistochemistry, it stains very positive for ACTH, which was expected, as this is a corticotroph type adenoma, and it also stained for the marker TPIT. And his final diagnosis was a pituitary adenoma, corticotroph type. These are the post-op scans, T1 post-contrast, and in the pre-op scan on the left, I'll get it to a point, you can see the tumor. And then in the immediate post-operative period, 1 day after surgery, there is no apparent enhancing in the resection cavity. Dr. Omida, I don't know if you want to comment here.
No, I agree. I mean, we don't see any tumor left, but once again, the most important point is to see how the hormones will behave. So MRI looks awesome, surgery looks awesome. Let's see how the hormonal function goes. Let's hear from the endocrinology team. I think it's okay. Yeah, let's hear from endocrinology team.
Okay. This is our postoperative course, day 1. Dr. Barsakova, do you want to comment on her immediate endocrine labs following surgery?
Yeah, basically we see how her ACTH drop, which, like suggestive, pretty good response after surgery, as well as her cortisol really dropped, to 5.6 in the afternoon. We did see, like her prolactin also kind of improved at that point, but we start patient on dexamethasone 1 milligram daily, because we do know what they do have, suppress adrenal axis, which basically, in dexamethasone prefer more over hydrocortisone because it's more long acting, and patient doesn't really feel great after the surgery. And that's why dexamethasone is like kind of better or choice for the patient who has a Cushing disease.
And she was discharged home on day 2 with neurosurgery and endocrinology follow-ups. This was a paper that I was going to talk about briefly, but for the sake of time, I will skip past it. It's a good paper though. It talks about remission factors or predictors for disease relapse in patients who undergo Cushing's disease, and just the importance of having to follow these patients long-term, because we still have no good predictors for disease relapse in this patient population. And then this is her follow-up with endocrinology this past Wednesday. Dr. Barsakova, want to comment?
Yeah, no evidence of, secondary hypothyroidism. Basically, she has a mild hyponatremia, which we actually know with patient can after surgery can go like triphasic. Initially, one of first day they can develop diabetes insipidus, then normalize, and then they can go to SADH. We place, patient on fluid restriction at this point, but her prolactin, still kind of went up a little bit. Most likely it's due to still stock effect and significant surgical management. Her SATH in a good range. We do see which her cortisol suppressed, but which is a good indicator, which gonna takes for some time for her. We switch her to right now I think to hydrocortisone at this point. But she can, she was aware she may need to use dexamethasone because she may not feel, clinically well after being, so many years, in a pushing state with hyperparathyroidism.
Just an additional comment. So that sodium is with 4 days of fluid restriction to 1 liter. And the highest risk patients for delayed isolated hyponatremia are female and ACTH tumors. She actually was asymptomatic in clinic, and I asked her to extend her fluid restriction until today. But it's really remarkable that the strength of that vasopressin release from the pituitary and how strong that is in the ability to cause hyponatremia. And you may say, well, if she's not drinking, how can she have diluted herself? Well, because she's also peeing out sodium at this point. So she's losing it in the urine. And this is why it's so important that we counsel our patients on not having too much fluid intake in that period after the surgery.
And also, just to be very honest, the only reason why we can do this is because Dr. Sampson has been so amazing. This patient left in post-op day number 1, is that right, JP? Yeah. So the only reason why we can is because Dr. Sampson and her team, they just do such an amazing job following closely, watching them every day. She personally calls them on the weekends, I know, and it is amazing. Thank you, Dr. Sampson. Beautiful job and beautiful case. And I saw Dr. Vargas also commenting on the amazing dissection of the cavernous sinus against the carotid. This is very few people in the world do that, and JP does it beautifully with Kai, with our team. So beautiful case.
Thank you, Dr. Q. Thank you, everybody, for the comments. So I guess just for the sake of time, so we have time, maybe we go to the next case.
Sounds good. Thank you, everybody. It was a pleasure presenting this morning.
Great job.
Thank you, Chase.
Thank you, Chase. Amazing.
We appreciate it, Chase. Where are you in medical school, Chase? Remind us.
I'm a 4th year medical student at the College of Osteopathic Medicine in Philadelphia.